payments are for just exactly the reasons that I'm arguing are the right reasons here. Greater complexity, and to the extent that we can measure it, greater quality. I'll say more often, greater complexity, and sometimes because of cost shifting. That is underpayment by governmental payers. We tend to not talk about one of the elements when we talk about all the successes in universal coverage. We tend to not talk about one of the elements that has not been a success, and that was the commitment of the state to significantly increase its payments to Medicaid providers that dropped by the wayside in the budget crisis. So those are factors. Sometimes we pay higher payments because of market power, because we are in negotiations, and whether that is because of the academic nature of an institution, whether that is because of the brand reputation of a group of institutions, or whether that is because of geographic location. Sometimes we pay higher payments because of those factors.
What would happen if you went to your contracted network and said, we're basically paying the same for all of our physician services and all of our hospital services, except we're going to account for differences in intensity of services based on the population served, and let's assume for now that quality costs more, so we're going to pay more for quality. What would be the response of your network?
Well, we do that in a fair number of our negotiations, and some providers respond enthusiastically to that. Some providers respond with growing accommodation to
that. Ellen, how would you respond if Jim said, I'm paying you the same as everybody else, except you got higher case mix, which you just told us about, so I'm going to adjust you for that, but that's it. Otherwise, let's say your quality looks exactly the same as everybody else, so you get the same payment as everyone on the. Yeah.
Well, I'd like to adapt that to something that I think is more usable than the question. And that is, I fundamentally believe a real fix in this market is to have a common fee schedule across all health plans. Not that we're all rate setting, we're not talking about the intense rate setting, but that fee schedule should be moderated with inflators in private negotiations, not state-run negotiations, private negotiations. So perhaps the hand of the state could come in and develop a foundation that's transparent, that we all know the basis of, that isn't different from health plan to health plan. And then in our private negotiations, we talk about the issues you raised, Michael, and that Jim spoke to, whether it's the fact that we have a high Medicaid population, or a high case mix, or a teaching mission, all of which are legitimate variations in price. So I think rather than talking about what's fair and what's not fair, we ought to do it more scientifically. And we ought to do it more transparently so that we have a common understanding that's irrefutable. And then we inflate it based on who we are, what our quality is, what our mission is, and so forth. And there's been a resistance to even thinking about that, and I frankly don't know why.
All right, well, your time is good since we've got the new Price Reform Commission to talk about new ideas.